سلتك يلا عيش. الله اسبوعين. اسبوعين.
مستعدين للأوسكي؟
ايه قبل العطل.
الليفل بيدي ما حنعمل قبل الأوسكي بس try your best إنه بحكي دائما للجروبس إنه تاخذوا as much cases as possible. Okay? وما تاخذوا case for granted يعني دخل مريض هيك وشخص هيك try to think it yourself. يعني دائما think holistic differential. Not only for the sake of the exam. But for you as a doctor, it's all about exercising how to think about differential diagnosis. Okay, so in today's lecture, we're trying to review the key concepts of primary immunodeficiency. The immune system is a bit complicated to understand, so we'll try to put a grip around the basic concepts. So hopefully by the end of this lecture, you'll be able to differentiate the main aspects of primary immunodeficiency disorders and the specification of each one. Okay, so primary immunodeficiency is also known in the new time nomenclature as inborn error of immunity. And this new name actually is to imply how the strong roots of genetics in primary immunodeficiency. So each and every primary immunodeficiency disease has a genetic problem, a genetic mutation. With the improvement of the whole genome sequencing and the genetic testing nowadays, specifically in developed countries, every day a new primary immunodeficiency disease is being discovered. Up till this point, more than 403 primary immunodeficiency diseases have been discovered. What is primary immunodeficiency or inborn error of immunity? It's a group of heterogeneous diseases. As I say, each and every one of them has got an underlying genetic defect or mutation. The main characteristic is either an absent or dysregulated or poor arm of the immune function. So we've got, let's say, we have a problem in a specific cell of the immune system. It's either absent, the cell is not being produced, the cell is being produced or it's not getting regulated and doesn't get the maturation differentiation required for its function to happen, or the cell is there but the function is dysregulated. Okay? And it takes a lot of interaction between all arms and all components of the immune system for our body to function well and to be well protected. Don't forget that primary immunodeficiency disorder doesn't only mean having or getting infections. Also, nowadays, with more discoveries, more research, primary immunodeficiency diseases lead to so many cancers and tumors. As well autoimmunity and the appearance of new allergic diseases. I like to call primary immunodeficiency as the common uncommon. So it's very rare to hear about a child getting a diagnosis of primary immunodeficiency, right? So far, how many kids have you encountered with primary immunodeficiency diagnosis? Maybe nil so far, right? So it's very uncommon to hear a child with this diagnosis. However, it's known that estimated more than 6 million people currently do have some sort of an immune disorder. However, without more than 90% of them, they don't have a specific diagnosis. So what's really challenging in the field of immunology is to get a final diagnosis. And this, again, in some aspect depends on the presence of some sophisticated investigations like genetic testings, which in countries like Jordan is not very available. So that's very challenging, specifically in countries like Jordan, to get a patient diagnosed. We know that so many kids die in hospital with severe sepsis, immune dysregulation, chronic inflammatory diseases without diagnosis, which is a shame. Okay. As I said, if a kid does have primary immunodeficiency, that means susceptibility to having viral, bacterial, fungal, protozoal infections. As a acute infections, but also as well inability of the body to clear these infections quickly. So this turns into chronic infections, which carries a high rate of morbidity and mortality as well. As I said, also primary deficiency can predispose to cancer and autoimmune diseases, allergies, and chronic inflammation. For example, mentioning chronic inflammation, like inflammatory bowel disease. So there's a recently discovered genetic mutation that predispose kids to have very early onset inflammatory bowel disease, for example, like Crohn's disease. So they present very early in life, in the first months of life, with manifestations of primary immune deficiency manifesting as Crohn's disease or inflammatory bowel disease. Alright, like we call it interleukin 10 deficiency. So again, primary immune deficiency is not only getting infections, alright? So it's about inflammation, autoimmunity, new allergies, and malignancy formation. Okay, the main two arms of our immune system, which should work and should integrate with each other, are the innate and the adaptive. I think you've learned about these in your basic levels. So the innate immune system, always remember the I. I means instant, so it works immediately, immediate, and I integrates with the adaptive immune system. So the innate immune system is very important, we know that, because it's the first defense mechanism of our body against any pathogen, alright, either a foreign body, a virus, a bacteria, etc. Because as you're sitting now in this hall, your body is exposed to pathogens around you, your skin is exposed, the epithelium covering your respiratory tract, for example, the mucosa covering your GI tract, are constantly dealing with pathogens or, for example, flora that sometimes turns to be opportunistic. So the first defense mechanism against those is the innate immune system. So the main components of the innate immune system, let's just count them: neutrophils, which is a phagocytic cell, right? Macrophages, a phagocytic cell as well. Monocyte, and we know that monocytes later will give rise to either macrophages or monocyte-derived dendritic cells. What is dendritic cells? Dendritic cells are antigen-presenting cells. So they present any pathogen or offensive microorganism to the involved immune cell to deal with it. It's like a messenger or a billboard saying, we need help here, okay? And of course the complicated complement system with all of its proteins, we're not going to go deep with that. The natural killer cells, which also not only play a crucial part in fighting off infections, but as well to prevent malignancies and mutated cells from proliferation. As well, part of our innate system is our epithelial skin barrier and some secreted enzymes in our mucosal cells. Despite the fact that our innate immune system is the first defense mechanism against infections and pathogens, it lacks specificity. Okay, so for each and every type of pathogen, the innate immune system acts in the same manner. Okay, it doesn't change its structure, it doesn't tailor its mechanism of action to fit that specific pathogen. Okay, they're just one way, one guideline that they follow to fight off infection. So it lacks specificity. All right, and this limited specificity and diversity is reflected by what we call limited number of pattern recognition receptors. So the receptors on their surface doesn't recognize specific patterns. They don't need a specific pattern to recognize. They don't have a specific shape of receptors to attach to a specific shape of antigen. They just work the same for each and every foreign body or pathogen. And they don't have enhanced activity upon subsequent exposures. So if you are exposed to pathogen A now, and your body gets exposed to the same pathogen like a year ahead, 5 years ahead, 10 years ahead, the mechanism of action, the speed of response would be the same. Okay, the efficacy doesn't improve with time or with subsequent exposures, which is the contrast of what we're going to talk about in the adaptive immune system. So the adaptive immune system basically is composed of B cell lymphocytes and T cell lymphocytes, and we know that they fight off all sorts of pathogens, viral, protozoal, fungal, intracellular and extracellular. There's secrete proteins like immunoglobulin, which is secreted by plasma B cells, which is important to titrate antigens and pathogens and be presented to phagocytic cells to engulf them which after they got carried by the antibodies or presented by the antibodies on the surface of an antigen-presenting cell. The difference between the adaptive and the innate system is that the adaptive is very smart, okay? So it's capable of like improving itself upon subsequent exposure, okay? So if you're now exposed to pathogen A and then you're again exposed to the same pathogen a year ahead, the response would be much more quicker and much more efficient because it has what's called memory cells. Okay, so that's the difference between the adaptive and the innate. But again, they both have to integrate with each other to function optimally. So with adaptive, remember the letter A, acquired. So you acquire it through exposure, which is different from the innate. It's there, regardless you're exposed to a pathogen or not. Okay, so it's acquired. It awaits 8 days. It needs time. So from the time you get exposed to the pathogen, we need some time for the innate system to act, right? First, because it's the first self-mechanism, defense mechanism, and then the innate immune system will communicate with the adaptive immune system. The adaptive immune system needs to recognize this pathogen as a threat and then to start acting upon this, start to proliferate, differentiate, produce enzymes, cytokines, antibodies, etc. And this process needs time actually, days, sometimes weeks, okay? So await days, it needs time. There's no such a thing as immediate adaptive response, okay? And it's accurate, it's very specific. So imagine how like many millions, maybe billions of pathogens around you. As such, there are millions and billions of specific B and T cells. Each pathogen has a very specific cell to interact with, a very, very specific receptor on the surface of these adaptive immune system cells, okay? So things doesn't work haphazardly. Everything is specific, everything is regulated, and it's extremely accurate. It's very important that the adaptive immune system plays a role against autoimmunity because elements of the adaptive immune system, like T cells, one of their main function is to differentiate between self and non-self antigen, okay, which is what we call tolerance. If we fail to recognize self-antigen as self-antigen, what's going to happen?
Autoimmunity.
We're going to attack our own cells, which is autoimmunity, okay? And autoregulation. Alright, the last bit of the arms of the immune system is the local immunity that we gain. So it's a locally initiated immune response, however, gives a global immunity. So have you ever thought why, if you receive an oral drop of a vaccine like the OPV, why do you develop an overall immunity that works and responds at any site of your body if exposed? Have you thought of this before? So whenever there's a local immune reaction or a local immune response, like what happens with secretory IgAs, for example, produced in response to OPV being ingested and being in contact with our mucosa, okay? This secretory IgA will start to proliferate, or initiate an immune response, and then communicate with other arms of the immune system, leading to global proliferation and a global immune response, okay? So this starts locally as with vaccines or as with getting infected. For example, if you get like an insect somewhere on your skin, if you're allergic to that insect, the immune cells will cause a systemic reaction, right? But you were like, the insect was very local. It's the same concept, okay? The ability of this local immunity to produce a global one. Before moving and digging deeper in primary deficiency disorders, let's just differentiate between active and passive immunity, just to make sure that you know the difference very well. So active immunity, meaning that your immune system is working very hard, very actively to produce this immunity by For example, being exposed to an antigen, calling off the innate immune system and then adaptive, and T cell, B cell proliferation, and then antibody production. This is the natural history of developing an active immunity. Okay? While in passive immunity, immunoglobulins are received passively. And they're being infused, ready to use immunoglobulins. With active immunity, it's again induced either naturally by an infection or artificially by vaccination, given, for example, a purified protein of a specific pathogen. However, with a passive immunity, you just take the immunoglobulins either by transferring these immunoglobulins like IgGs from placenta, mom to fetus, or by just giving sub-Q or IV injection of immunoglobulins. Active immunity is long-lasting. Do you know why?
Memory cells active.
Because to develop this immunity, as we said, both innate and adaptive need to integrate, and the result will be the activation of the adaptive immune system arms, and then calling off a response, and having a memory cells also being involved on subsequent exposure. That's why the immunity that we get from active, like the active immunity after an infection or a vaccine, like a cold vaccine, is a long-lasting one. So you might be, for example, if we mention measles, you should be protected against measles for 10 years or more, for example, after getting the vaccine. However, with passive immunity, that's for a very short period, because we give ready-to-use immunoglobulins, they circulate, and then we have a half-life for immunoglobulins, about 6 weeks, and after this, they will start to fade away. Okay, so it's for a short period of time. And an example of passive immunity where we give immunoglobulins, for example, if you are susceptible to having severe viral infection and you got exposed to chickenpox and you don't want to get an overwhelming infection, what do? You get post-exposure prophylaxis like immunoglobulins to try and titrate these viruses, prevent them from proliferation. Okay? After the job is done, that's done. Antibodies will circulate for a while, if not consumed totally, and then the number will decline until fade away. Again, active immunity has memory, but it's not the case for passive immunity. Active immunity, we need booster doses for active immunity, right? So, for example, with a COVID vaccine, we needed booster doses of the vaccine. But it's not the case for passive immunity. They're not as effective. How? Okay, so for, let's say, if you gained immunity against a specific vaccine, so the vaccine done its job, it stimulated your immune system, your B cells got stimulated, your body produced antibodies to that disease, for example, to that virus. You will be protected for a long period of time on subsequent exposure. And even if you get the infection will be mild, much milder than if you did not receive the infection, right? However, with time, again, antibodies will start to decline the concentration, okay? So you won't be efficiently protected, okay? So that's why we give booster doses, to boost your immunity again, to tell your B cells to produce a little bit more antibodies just to get you covered and protected. However, if I need for the passive immunity, if I was exposed to chickenpox and I want to get prophylaxis and I received immunoglobulins, and then the virus started to replicate in my body, and the antibodies start to titrate and attach to these viruses, okay? Now, the antibody will do its job. If I require about, let's say, 1 gram per kg or 2 gram per kg of this immunoglobulin to just titrate the virus, if I give 20 gram per kg, will the outcome be different? No, because I need just that limited or specific number of antibodies to titrate the viral load, right? But if I give more, nothing more is going to happen. The efficacy of what I'm giving is not going to change. The outcome will not change. Okay? واضحة؟ Correct? Okay. In active immunity, there is what we call a negative phase. So just to explain what does a negative phase mean. So it's a phenomenon. It's not commonly seen in technology. Sometimes we see it. So after you vaccinate, for example, patient X, in the first 2 to 3 days, their immunity against this pathogen will be less effective or less predominant than it was before the vaccine. So worse than before the vaccine, but just for a transient period, 2 to 3 days. And then the immune system wakes up, and then the immunity will start to spiral up, and then you will have the immunity that you want, the active immunity that you want. So we call it a negative phase, okay? Just a transitional period that happens after vaccination. Not always, sometimes, but this is not seen in passive immunity. Active immunity is not useful in immune deficiency. Do you know why?
ما في اكشن اصلا بين الاميون سيستم، ما في اكشن بين الاميون سيستم
احنا
والانتيجين.
قلنا انه absent as a component of the immune cell, or dysfunctional, or dysregulated. صح? Okay. So it doesn't matter. For example, if you give a vaccine to a kid with X-linked, for example, A-L34, or someone with a B-cell problem, someone who can't produce antibodies, what's going to happen?
You have a disease.
Will have disseminated illness rather than developing immunity towards it, okay? Because they don't have B cells to produce antibodies, right? However, passive immunity is one of the most important breakthroughs for patients with primary deficiency, susceptible patients who can't fight off infections. So patients with primary deficiencies often need to be given this passive immunity to protect themselves, okay? Alright, so the common immune deficiencies that we're going to discuss and brief today are B-cell disorders like XLA or A-gamma globulinemia, selective IgA deficiency, common variable immune deficiency. This is for B-cell disorders. T-cell disorders like chronic aplasia or DiGeorge syndrome, IL-12 receptor deficiency, autosomal dominant hyper-IgE syndrome, or what we call it JOP syndrome, chronic mucocutaneous candidiasis. For combined B and T cell disorders, we have SCID, or severe combined immune deficiency. We've got ataxia-telangiectasia, hyper-IgM syndrome, Scott-Aldrich, and this is combined, so we've got both arms affected, but in different proportions. And we've got the phagocytic dysfunctions like leukocyte adhesion defect. We've got 3 types, but we're going to talk about type 1, which is the most common. Chidiac-Higashi syndrome and chronic granulomatous disease, or CGD. Do the names ring any bell? Do they sound familiar? The names of the disorders, are they familiar or not? Yes? Some? Okay. We'll start with B-cell disorders. Okay. The first type of B-cell disorder is what we call X-linked A-gamma globulinemia. So just look at the name. It's X-linked, so it,
Males better than females.
exactly, male predominance. The defect in this disorder is in what we call BTK gene, or tyrosine kinase gene, which is very crucial for the B-cell maturation. So there's no B-cell maturation, and we need a mature B-cell to differentiate into plasma antibody-producing cell. So without this gene, B-cells will not differentiate, and we don't have antibody production. Okay, do you understand the concept?
Yes.
Okay. So those with inability to produce antibodies will have problems, serious problems with bacterial infections, okay, and some viruses and parasites like Giardia. Infections usually, they start to manifest after 6 months, and we know why, right? Because in the first 6 months of life, you're protected from your maternal immunoglobulin, so you are very well covered. So after the age of 6 months, your bone marrow will need to start producing mature B cells that should proliferate, differentiate into plasma cells, to produce antibodies, right? So after 6 months, if you have X-linked agammaglobulinemia, the problems will start, okay? They will have decreased immunoglobulins of all sorts. Immunoglobulin G, IgG, IgM, IgA, IgE, okay? All types of immunoglobulins will be decreased. If you look peripherally, you will not be able to see B cells, because B cells do mature in the bone marrow and then they got expelled out to the blood. So if there's a problem, or if there's a problem in maturation, you will not see peripheral B cells at all. On examination, if you examine these kids, you will see scanty lymph nodes and sometimes no tonsils. Why?
Maturation. T cells, related T cells, maturation.
The structure of your tonsils is 80% B lymphocytes. Okay, so if there's no B lymphocytes peripherally, you will have absent tonsils or very small tonsils. It's extremely contraindicated to give those live attenuated vaccine because you're going to end with life-threatening disseminated infection. And those patients, not only they're susceptible to having severe life-threatening bacterial and enteroviral infection, but as well are very susceptible to have autoimmunity like SLE, and the percentage is very high. About 20% of them will at point of their life develop an autoimmunity like SLE. So if you look at this graph, you can see a boy, right, with a bad tire, right? So a boy, just remember, because it's X-linked, a bad tire, B and T, the gene is BTK gene, the tyrosine kinase gene. And again, they're susceptible to have recurrent bacterial and enteroviral infections, and they have no B cell maturation. In autoimmune diseases doesn't mean your antibodies are causing autoimmunity. Immune dysregulation or immune dysregulation maybe, there are many other parts or cellular components of your immune system are in charge of getting your immune system well regulated, like T helper cells. Okay, so it doesn't need to be with antibodies. Okay. So you will learn by the end of this lecture that B cell has a function, T cell has a function, but they need to work in a parallel way. They need to talk to each other for your immune system to be regulated. This is number one. So the function of B cells not only to produce antibodies, but to also regulate T cells. Okay. So I'm going to explain that as the lecture goes. So B and T cells need to talk to each other to keep your immune system regulated. If this is absent, you will have dysregulated immune system and autoimmunity. Okay? So next is selective IgA deficiency. From the name, as it implies, there's only problem with mainly IgA, immunoglobulin A's. Consider the most common primary immune deficiency. So if you take 500 people, one of them will have low levels of IgA, okay? However, the good news is that most of them will be asymptomatic, totally asymptomatic, symptom-free, okay? Minority of them might have some problem like GI problems, GI recurrent infections, respiratory infection, because we know the role of secretory IgA, and they are mainly one of the important defense mechanisms in our airways and the GI tract. Also, people with selective IgA deficiency will have some autoimmune disorders, a problem with atypical disease like eczema and asthma, and they will react with anaphylaxis to any IgA-containing blood product. Okay, so if a patient is diagnosed with IgA deficiency, it's forbidden that you give them regular transfusion, blood transfusion. They can't receive regular packed RBCs. You need to wash them. Wash them, like removing plasma, all plasma protein, for them not to have anaphylactic reaction. Okay? So anaphylaxis to IgA containing products, and some of them might have as well most of them, sorry, will have normal IgM and IgG levels. It's mentioned in literature that they also there's increased susceptibility to giardiasis. So selective IgA deficiency, remember A, asymptomatic, the majority of them don't have any symptom. A, airway and GI infections, they're liable to those infections if they are symptomatic. A, autoimmune disorder or disease. A, atopy, anaphylaxis to IgA containing products. Alright? The next one is common variable immune deficiency. Okay, so the problem here is, again, a defect in B cell differentiation. Okay, the exact cause is still unknown. However, till this moment, many defects, genetic defects, have been isolated, like ICAS, TACI, CD19, 20, 21, CD80, etc. So they are being accused to causing common variable immune deficiency. Both sexes are equally affected, males and females. There's no male over female predominance. Usually the presentation, the typical presentation of common variable deficiency in the second or third decade of life. However, I have explained this in my clinical rounds before with, I think, more than one group. So there is a subcategory of babies who do have what we call transient hypogammaglobulinemia. What is transient hypogammaglobulinemia? As I said, in the first 6 months of your life, you're covered by your maternal immunoglobulins, right?
IgG.
After 6 months, your bone marrow should stand up and start acting, producing B cells that should differentiate, mature, and produce plasma cells and antibodies. Okay? This process, we call it transitional process, from depending on active, on passive immunity to building up your own active immunity. It needs some time, okay? However, in some population, the process will be slower and not very sufficient. So they will have a period of dipping down in their immunity, like they will have transient hypogammaglobulinemia. So there's no sufficient production of immunoglobulins, okay? It's transient, it's benign. Usually this doesn't cause them life-threatening or severe problems. But if they happen to present with an infection, if it happens to their doctor to send immunoglobulin level, they'll be found to have low levels of immunoglobulins. And all you need to do is to follow them up. Why do we need to follow them up if this is transient and if this is a benign condition? Do we know why? Okay, because a very small proportion of those with transient hypogammaglobulinemia, their immunity actually will not spark up, and if it continues to be defective during their adolescence and early adulthood, they will turn into common variable immune deficient patients. Okay, so transient hypogammaglobulinemia, benign, self-limiting, needs time. The immune system the immunity will spiral up. They will start to produce their own antibodies at one point, but a small proportion of them will continue to have low levels of immunoglobulins, problem with B cell differentiation, and they will turn to being common variable immune deficient patients. Okay, what's the problem of having common variable immune deficiency? As we say, no B cell differentiation, no antibody production, no proper antibody production. And this will lead to susceptibility mainly to sinopulmonary infection. Remember that one of the main functions of antibodies is to fight off pyogenic infections or pus-forming microorganisms like strep, staph, etc. If you don't have those antibodies, you will have a problem with recurrent infections, bacterial ones, mainly sinopulmonary and common viral immune deficiency. And we know that recurrent chest infections, what does it lead to? Bronchiectasis. So also common variable immune deficient patients, some of them might be very unlucky and develop bronchiectasis, and some of them might die, although their life expectancy is not very shortened. Another problem with common variable immune deficiency is the autoimmunity and the immune dysregulation, which puts them at a higher risk of developing cancer in the future, basically most commonly non-Hodgkin lymphoma and gastric carcinoma. This is higher, it has higher prevalence in patients with common viral deficiency than the general population. As I said, the pyogenic infections that they are susceptible to have usually, most commonly are Haemophilus influenza, Streptococcus pneumonia, and Staphylococcus aureus. And again, because they have a problem with B-cell differentiation and antibody production, you will have low levels of IgG, IgM, and IgA. So looking at the diagram, just to consolidate the information. So both sexes are equal, as you can see. She's got pulmonary infections. As a result of bronchiectasis, she has a high risk of having gastric carcinoma, and she's carrying a pot with very minimal immunoglobulins, so she's got decreased immunoglobulin levels. Okay, now moving to T-cell disorder. One of the most common T-cell disorders is DiGeorge syndrome. I think you've heard about DiGeorge syndrome. Have you come across any case with DiGeorge? No? Really? Okay. So DiGeorge syndrome, the problem happens during the embryological development of the third and fourth pharyngeal pouches due to chromosome 22 microdeletion. Okay? This will lead to either absent or hypoplastic thymic gland, so thymus hypoplasia or thymus aplasia, parathyroid also hypoplasia or aplasia. Okay? Because the third and fourth pharyngeal pouch will give rise to those structures. How do they present? So it's microdeletion, generally microdeletion, through mode of inheritance.
Okay. Summers microdeletion.
Different, صح هذا خلها. This is the dominant issue والmicrodeletion issue ثاني, صح؟ Okay. Alright. طيب. How do they present? Because of their parathyroid gland hypoplasia or aplasia, the key of diagnosis, usually, if the doctor think of it as a differential diagnosis, when we see a kid with tetany or hypocalcemic seizure, okay, always a neonate who's just born with a hypocalcemic seizure or severe hypocalcemia not responding to correction, we have to think of DiGeorge syndrome, okay? So if that's the case, if someone presents with hypocalcemic seizure, we need to check for T cells. So we need to do close items to make sure T cells are there and present. And we need to make sure that these T cells are not dysregulated and they are talking very well to B cells, and the B cells can produce antibodies as well. Because B cell production is also dependent on communication between T and B cells, okay? So if that's the case, if they don't have T cells, why do you think they don't have T cells? شو دخل microdeletion والthird? Excellent. So احنا قلنا الماتريش of the B cells وين بتصير bone marrow, صح؟ هلا T cells are different, so they get expelled from the bone marrow as undifferentiated. Okay, so they need to travel. They know their way very well. They need to travel to the thymic gland, to the thymus, and that's where they get differentiated and become mature instead of naive, right? صح؟ بعدين بيعطونا CD4, الهيليبوid, CD8, cytotoxic, etc. So if this doesn't happen, your T cell, if there, is dysfunctional and somehow might be dysregulated, okay? So they will have increased risk to viral infections. So any virus can cause a real problem for them. Even rotavirus might be a problem. RSV can be a life-threatening disease, for example. So viral infections, fungal infections due to T-cell deficiency. They also have very specific core feature in their faces, like core facial features. They have common trunk abnormalities like tetralogy of Fallot and truncus arteriosus. Again, if you test them, flow cytometry, it will show low number of T cells, parathyroid hormone, and calcium. Okay, studies do show that severity and outcome correlate with how profound or how bad their hypocalcemia is. So if a kid presents with DiGeorge, for example, kid X, for example, إجا DiGeorge syndrome diagnosed, بس ما كان في عنده hypocalcemic seizure, I think I would be very optimistic that his T cells are okay and he's unlikely to have a problem in his immune system. So not every patient with DiGeorge syndrome does have T cell dysfunction. Actually, the majority of them is fine, will do fine somehow. Okay? حكينا ممكن تكون aplasia كانت مش موجودة، ممكن hypoplasia، ممكن ضل منها جزء عن T cell are still differentiating. In some patients, interestingly, كان عندهم absent thymic shadow on X-ray. Fairly ما عندهم thymic thymus, it's absent, it's not there. But we don't know why. The T cell is fine, it's functional, and it's getting differentiated just fine. Some theories suggest that there might be ectopic thymic tissue somewhere, hiding somewhere. So it's one of the secrets that's not unleashed up until now. Okay? Sorry? Yeah. No one knows. So the microdeletion is the same, chromosome 22, but there's different phenotypes. So we have genotype, phenotype, right? Right? It's the same. So this chromosome is deleted or microdeleted, but the phenotype might be different in different population. And don't forget the effect of epigenetics on this as well. I don't have a very precise answer, but we don't know. So some patients with the same microdeletion might have a totally aplastic thymus. They have no thymus at all. Some of them might have hypoplastic thymus, and they're just doing fine. Okay. Even the cardiac anomalies, they're not all the same. Some of them have, for example, truncus arterioris or challenge of Fallot, the others might be just okay. The facial features as well. With patients with DiGeorge syndrome, intellectual abilities are also different. They might have learning disabilities, but in different degrees. So there's just no one way to say that they don't have the same phenotype or the same manifestations. But yes, the same microdeletion. Okay, so just to remember, so this graph showing George Bush and George Washington, so died George. Okay? So 22, so there's a microdeletion chromosome 22. So remember catch 22, so DiGeorge catch 22. C stands for cardiac abnormalities like truncus arterioris and challenge of Fallot. A, abnormal faces, and we say that abnormal core spatial features. T, thymic aplasia or hypoplasia. Cleft palate, many of them they do have cleft palate, others are just fine. Hypocalcemia in different degrees, and as we say, chromosome 22, 11 microdeletion. Okay, the next one is IL-12 receptor deficiency. For me, this is one of the most fascinating mediators, inflammatory mediator in our immune pathways. So interleukin 12 is very important. Its interaction with T cells, basically T helper 1 cell, is very important, very crucial to produce interferon gamma. Interferon gamma is needed to fight off and suppress mycobacterial infections, mainly mycobacterial fungal infections. If there's a problem with IL-12, which is an autosomal recessive problem, so there's no IL-12 receptor. IL-12 will not communicate, will not attach to a receptor. There's decreased T helper 1 response, and there's absent or decreased interferon gamma. This will lead, as I say, to disseminated or severe mycobacterial and fungal infections. One of the early presentation of someone with IL-12 deficiency is that if there's someone with this genetic disorder, this primary deficiency, and we don't know yet, because they're just born and they're not manifesting with anything, if we give them the BCG vaccine, it will be catastrophic. They will have what we call BCJosis. They will have enlarged lymph nodes everywhere. They will be very sick, and this could be life-threatening. Okay, and that might be the first key or the first hint of diagnosis. Okay, so the diagnosis you need to send what we call cytokine assay to check for, and then genetic to confirm the diagnosis. Okay, Job syndrome or dominant IgE syndrome, as the name implies, autosomal dominant. Hyper IgE will have increased level of IgE in globulin B. So basically, it's a STAT3 mutation leading to T helper cell 17 deficiency. Okay, this T helper 17 is very important to recruit neutrophils to where they are needed. Okay, so if you've got hyper IgE syndrome, neutrophils will not go to the sites of where they are needed. So the bone marrow is fine, the production is fine, the number is fine, but they do not know the way. Okay, they lost their way because there's no T helper 17. Okay, patients with Job syndrome or hyper IgE syndrome, they have coarse facial features with long faces, long ears, etc. They tend to have recurrent cold abscesses, okay, like Staphylococcus aureus abscesses. They have, sometimes when you examine them, you might see they turn primary teeth. So if you suspect someone with hyper IgE syndrome, look at the size of their teeth and the shape. Sometimes they look like the primary teeth, very small, okay. They are very liable to have eczema as children and as adults. They tend to have fractures with minor trauma and increased levels of IgE antioxidants. So remember IgE, hyper IgE syndrome or Job syndrome. Remember Job's fate, the word fate, the acronym fate. F stands for faces, we've got coarse facial features. A, cold, non-inflamed abscesses. Why are there cold abscesses? Do we know why? Excellent, and there's no neutrophil formation. Right. Retained primary teeth, T stands for teeth, and E stands for elevated level of IgE and eosinophils, and eczema as dermatological manifestation of hyper IgE syndrome. Okay, chronic mucocutaneous candidiasis. Again, it's one of the T cell dysfunction disorder. The problem is genetic, inherited, and the genes that encode for IL-17 or its receptor. So the problem is in IL-17, interleukin 17. Patients will present with recurrent candidiasis or Candida albicans infection to the skin. However, this infection tends to be non-invasive. Okay. Now, one of the ways we test T cell function is that we need to expose this T cell to Candida albicans, okay? Because T cells are, so the most important defense mechanism against Candida albicans is T cells. So if a T cell comes across Candida albicans, this should trigger proliferation. This means T cells are fine. T cell proliferation is fine, which means IL-17 and its receptor is fine as well. So in those patients, there will be absent in vitro T cell proliferation in response to Candida albicans antigens. And again, another manifestation is absent cutaneous reaction to Candida antigen. Because we say immunity can start at the level of locally, at the level of your skin, right? Have you ever seen a PPD test for TB? Tuberculosis test,
اللي هو بيصير فيه anaphylaxis إذا كان.
Because you need to track T cells to the area to see a localized reaction. This is the same with Candida albicans. There's no cutaneous reaction to Candida antigens. Okay?
دكتورة كونه ما في cutaneous reaction كيف بدك تعرف البيشنت إنه عنده أصلاً disease؟ كونه ما في signs of reaction.
Actually, the T cell proliferation at that part. There's no T cell response to the antigen. Okay. Okay, now combine B and T cell disorder. So we've got a problem with both. so not only one. So we'd expect this to be more severe than having isolated T cell or isolated B cell, right? Because a patient, let's say, with T cell problems or like mucocutaneous candidiasis, okay, they have a problem with Candida albicans, but they're fine with, they have no problem fighting off bacterial infection, for example. They produce antibodies, their B cells is fine, their B cell is talking to the T cell, T helper cells, and everything's okay. But if we have combined immune deficiency, that means both lines are affected, which means more severe manifestations. The most important one that you need to know is SCID, and as the name implies, it's severe combined immune deficiency. It's very severe, it is life-threatening if not treated promptly, okay? And basically the outcome depends on how early the diagnosis happens and how fast the intervention takes place. There are different genetic mutations and modes of inheritance. The most common one is the X-linked one, which is related to the A-L34 receptor gamma chain defect. There's another form, which is the autosomal recessive or ATA deficiency, adenosine deaminase deficiency. And the last one, when we have a JAK3 mutation, we've got a problem with major histocompatibility complex class 2, or what we call bare lymphocyte syndrome, which is much rarer than the X-linked form. How do they present? So we said that with B cell problems, they need time to manifest, so beyond the age of 6 months, right? However, with this, because it's got as well T cell problem, their problems, the clinical manifestations will start very soon. So will present to you less than 6 months of age. That can happen with chronic diarrhea, chronic gastroenteritis that they don't recover from, failure to thrive, sometimes skin manifestations, because not only they might have decreased number of T cells, but they might also have dysregulated T cells, and these dysregulated T cells cannot tell self from non-self antigen, so it might attack their organs like their skin. So they might present with very ugly eczema-like rash or dermatitis-like rash, okay? And then with time, they will have, when after the age of 6 months, they will have bigger bacterial, protozoal, fungal infections. And so as I said, it is a life-threatening condition, okay, and it needs to be diagnosed as early as possible. That's why in countries like the United States, United Kingdom, most Europe countries, Australia, Canada, they added a screening test to rule out SCID amongst the heel-prick test. So the heel-prick test, like in Jordan, what do we test for?
ممكن ثلاسيميا.
Thalassemia, no.
Mouse.
Heel-prick test. Hypothyroidism, G6PD, tyrosinemia, and some metabolic disorders, but we don't check for disease like SCID. SCID needs to be screened. The reason why, as I said, it's fatal, and the outcome depends on how soon you diagnose and how soon you intervene. The optimal thing to do is to screen patient with for SCID. How do we screen them? So this is heel prick test, that little drop of blood will check for what we call TRIC count, which is T cell receptor exogenous circles. What does that mean? When T cells get out of the bone marrow, again, and they go all the way to the thymus to differentiate. And with this process, the differentiation, they will leave behind some traces, which are what we call the exogenous circles, and then DNA fragments, okay? These can be measured from blood, from any blood sample, usually any venous blood or heel-prick test, capillary test, okay? So we count these TRIC counts. For a T cell to be optimally there, differentiating good, we need to have at least 30 circles. The number should be at least 30, okay? If the number is low, that means this SCID, it doesn't mean that this SCID does have SCID, okay? Because there are a bunch of other reasons to why the TRIC count might be low. But you need to make sure that this is not the case. So we need to do flow cytometry to check for T cell count, B cell count, etc. All right? So screening for SCID is the optimal way to diagnose it. TRIC screen, and then if there's any suspicion, you do flow cytometry And if flow cytometry is suggested for SCID, we send genetics, yes, but we don't wait for genetics to come back to treat. We directly say that we need to transplant this SCID because it's curative, it's cured with bone marrow transplant, and that's the only modality of treatment, except for ADA deficiency SCID, where we can give the ADA enzyme, the deficient enzyme. But otherwise, SCID patient need to be transplanted. If not transplanted, the outcome is very dismal, it's very poor. Actually, if we transplant kids in the first 6 months of life, the survival rate or the cure rate is 80%. So 80% of them, if they're transplanted, they will have a normal health, nothing wrong with them at all, okay, lifelong, okay? That's why it's crucial to diagnose them as early as possible. And as soon as they get diagnosed, we have to avoid all life attenuating vaccines. We know why now, okay? We need to give them prophylactic antibiotic until they get transplanted. And sometimes they might need immunoglobulin transfusion while we are getting them ready for transplant. Okay. It says there's no concern for rejection if we do transplant. Why?
And ما في T و B cells.
Excellent. No T cells. Okay. So the main component of the immune system that leads rejection is T cells, right? But they don't have any T cells or minimal T cells. There's no problem with rejection. Okay. One of the combined immune deficiencies is ataxia-telangiectasia, from the name ataxia. So they have ataxia-gate and telangiectasia, which is dilated angiomas or capillaries. So this defect is autosomal recessive, meaning what does autosomal recessive mean? Needs to mutate alleles, and because it's recessive, it can skip generations, right? But with the increased rate of consanguinity, like what we see in our community and Eastern community in general, it might appear in each and every generation due to the increased rate of consanguinity. Okay, so autosomal recessive, the problem is a defect in the ATM gene. Okay, so because this gene is defective, there's a problem with detecting damaged or broken DNA. هلا احنا نعرف بالcellular proliferation في check points صح؟ صح في check points بيكون أي cell that's suspected to be abnormal, it needs to be destroyed as soon as possible. Okay, and this needs many efforts from so many cells and mediators. One of them is the ATM gene. So those patients, they have a problem with that, with the DNA damage, which lead to failure to hold progression of cell cycle, and mutations will accumulate, okay? And it's one of the DNA breakage syndromes or diseases. Okay, so how do they present? The common triad, cerebellar defect cerebellar ataxia, spider angiomas or telangiectasias, and IgA deficiency, okay? If you screen them or if you test them, you'll find increased alpha-fetoprotein levels. IgA is decreased commonly. The most common immunoglobulin 3 decrease is IgA. However, you can also find low IgG and IgE levels. They might have global lymphopenia. They might have cerebellar atrophy, intellectual problems, increased risk of lymphoma and leukemia. Why is there increased risk for lymphoma and leukemia?
And ما في checking points.
Excellent. Then keep the cell malignancy. Contributed abnormal cell that doesn't get checked. It's continuous proliferation. Okay. So with ataxia-telangiectasia, remember the 5 A's. Okay. The first A is ATM gene or defect. Ataxia, angiomas, telangiectasias, IgA deficiency, and alpha-fetoprotein will be increased as well. Okay, and remember the eye, they have the pathognomic eye feature of the telangiectasia. Okay. Hyper-IgM syndrome. So this syndrome is very interesting. It's an X-linked recessive disorder. Now we say for our major arms of the immune system to work properly, both T cells and B cells need to talk to each other and interact in so many ways. Okay, one of the ways used are CD40 ligand and CD40. Okay, CD40 ligand is a protein present on the surface of T cells. Okay, this ligand needs to interact with CD40 on the surface of B cells. Can also be found on the surface of macrophages and follicular dendritic cells. Okay, so with hyper-IgM syndrome, there's a problem with there's a defect on the CD40 ligand on T helper cells. Okay. Okay, but why do we need this interaction?
عشان يصير activation البي cells to differentiate to produce plasma cells.
تمام. What's the first antibody that gets produced?
First
أول antibody
اللي هو
IgM. Excellent. أول شيء يصير IgM production. But let's say we got exposed to a specific antigen. The specific B cell got activated. It produced a number of IgM. What needs to happen then? This B cell needs to talk to the T cell, the T helper cell, through CD40 and CD40. Because this interaction is very important for what we call class switching to happen. إيش يعني class switching؟ يعني هذا الinteraction will tell the B cell that you need to switch not only for IgM, but to produce other forms of immunoglobulins like IgG and IgA and IgD. تمام؟ فهمنا؟ Those patients with hyper-IgM syndrome, they have a problem with this interaction. ما في CD40 ligand عن T cells. هذا الinteraction مش موجود. The class switching مش موجود. مع شو رح يصير؟ Continuous proliferation, continuous stimulation, more IgM production. صح؟ But they will end up having what we call hyper-IgM infections. Okay? Hyper-IgM syndrome. What do they present with? They present with pyogenic infections early on in life, or pus-forming infections, and opportunistic infections like pneumocystis, cryptosporidium, and CMV. Those infections need a regulated T cell to be fought, all infections. But with the absence of CD40 ligand, T cell can't do its job. Okay? So they will have serious problems with these infections. So they will have normal or increased IgM, however, low IgG, low IgM, low IgD. And there's failure to make germinal centers be lymphoid tissue. Okay. Any question? What? Okay. Wiskott-Aldrich syndrome, X-linked resistant disorder. Okay. The problem is in the WASP gene. Okay, which will lead to abnormal. So there's a problem in the leukocytes and the platelet. They're unable to reorganize actin in their cytoskeleton, which will lead to defective antigen presentation. Okay, so they have got a problem with antigen presentation. And all the immune response, it always starts with antigen presentation. Okay? This should not be a profound immune problem, ليش؟ لأنه في other antigen presenting cells, غير leukocytes, صح؟
Dendritic cells.
The other antigen presenting cells. They will have a problem with antigen presentation, but it's not profound. Okay? How do they present? With Wiskott-Aldrich, they present with atopic diseases like eczema. They will have severe, difficult to treat eczema. Recurrent pyogenic infections, because they have a degree of problem in antigen presentation. Also, they have an increased rate of autoimmunity and malignancy. If you test them, you will have decreased level of IgG and IgM, but with high levels of IgE and IgA. Platelets, because there's a problem with the structure of the platelet, they are low in number and small in size. Okay? To remember it with Wiskott-Aldrich, WA, water, remember the acronym water. W, Wiskott-Aldrich, T, thrombocytopenia, E, eczema, and R, recurrent infections. Now moving to the third part, which is the phagocytic dysfunction or disorders of phagocytosis. The first one we get leukocyte adhesion deficiency or defect. There are three types, type 1, type 2, and type 3, but we're going to only talk about type 1 because it's the most common one, the other ones are much better. It's autosomal recessive. The defect is in the LFA1 integrin CD18 protein, which is on the surface of phagocytes. Means that there's a problem with leukocyte chemotaxis. What does that mean? That leukocytes can't travel, or they're not being attracted to where they're needed. Okay? How do they present? They present with skin and mucosal bacterial infections. Okay? There will be absent pus. Pus نعرف ليش؟ لأنه ما في leukocytes عم بتروح. البus شو هو؟ هو necrotic inflammatory changes. هو immune response هو اللي بيخلي البus يصير صح؟ There is no pus and impaired wound healing, because we need a very potent immune system for our wounds to heal as well. Okay? And one of the questions we ask in history when we want to rule out leukocyte adhesion defect, when did the umbilical cord separate? So delayed separation of the umbilical cord beyond 30 days is an early sign of leukocyte adhesion defect. Okay? So those patients, if they are exposed to a specific antigen, their bone marrow will be stimulated, and the peripheral blood immune system cells will be stimulated, and they will be calling for proliferation of all sorts of cells. More white cell count will be produced, but they don't know where to go. Again, they lost the sign, they lost the way. So they're not acting. The infection is still there, and the bone marrow gets more stimulated because the infection will produce cytokines and inflammatory mediators, and this will lead to positive feedback again to the bone marrow. So more white cell count will be produced and sent peripherally, but there's no response. Okay. So during infections, if you do a full blood count, white cell count will be sky high, it will be very high, but without any improvement. Okay. Chidiac-Higashi syndrome. So Chidiac-Higashi, have you ever heard of this syndrome? Okay, it's an autosomal recessive disorder. Have you ever seen someone who's got albinism?
Yes.
Okay. So they might have Chidiac-Higashi, specifically it's partial albinism. So Chidiac-Higashi is an autosomal recessive disorder. There's a problem or a defect in LEST gene, which is a trafficking regulator gene. So, because they've got this problem in this gene, there's dysfunction and, on a macrotubular level, dysfunction in the phagosome-lysosome fusion. Okay? This will lead, how do they present? They present with progressive neurodegenerative disorders or neurodegeneration. They have lymphohistocytosis, so we can do peripheral blood flow. We might be lucky and see lymphohistiocytes, or when we do bone marrow aspirate, we will find those lymphohistiocytes. They do have a very characteristic feature, which is partial albinism, so their eyes will be very blue. They are susceptible for recurrent infections like staph and strep. They might have peripheral neuropathy as well. The granulocytes, if we look at them under the microscope, we will see giant granules inside. This is the case also for platelets. They have pancytopenia, some of them, not all of them, and some of them might have coagulation problems, so they might bleed easily. Okay? So, to remember, Chidiac-Higashi, remember the acronym PLAIN. P is for progressive neurodegeneration, L stands for lymphohistiocytosis, A is for albinism, which is, as I said, usually partial. I is for increased susceptibility for infections, and N is for neuropathy, which is peripheral neuropathy. Now, I know it might be overwhelming, so I tried to include graphs to explain or for you to remember the differences between all disorders. We don't want you to be like smart immunologists. It's a hard work to do, but we want you to know the basics, okay? And exam questions usually are very easy and straightforward. I think this is the last slide. Yes, CGD or chronic granulomatous disease. Have you ever heard of this? Okay. So how احنا قلنا انه neutrophils are phagocytic cells صح؟ So they need to engulf pathogens and destroy them by producing toxins صح؟ طيب. How does neutrophils do that? They do that by what we call forming a respiratory burst, okay, which is basically forming the active oxygen species. And all of the active oxygen species, like superoxide, who are toxic and microorganisms. So they help neutrophils to neutralize the pathogens, okay? Without this reaction, without the respiratory burst inside neutrophils, without the production of these oxygen species, neutrophils will not be functioning well, okay? So this is an excellent, mostly excellent. There are other modality of inheritance, but the most common form of CGD is X-linked. We might see autosomal recessive, where we have got two alleles, one from mom, one from dad. Usually, if that's the case, moms tend to be only carriers. They don't have any profound problems. This inability of neutrophils to produce those reactive oxygen species will make them more susceptible to be infected by catalase-positive microorganisms. Can you mention any catalase-positive microorganism? Pseudomonas, excellent. ايش كمان؟
ستريبتوكوكس أوريوس. لا.
ستريبتوكوكس أوريوس.
Is it catalase positive?
ممكن.
Strep? Catalase مش. Staphylococcus, yes. E. coli.
ستاف أوريوس.
Streptococcus.
طيب بغض النظر.
Staph, you mean Staphylococcus? The Staphylococcus is one of the catalase positive. E. coli, Listeria, Mycetogen, Pseudomonas, as you mentioned. Nocardia is another catalase positive microorganism. Serratia marquescens is also a catalase positive microorganism. And Aspergillus candida as well. So Candida and Aspergillus are all catalase positive microorganisms, okay? How do we diagnose them? So in the past, then we used to do the nitroglycerin dye reduction. So the dye will be reduced because there's presence of the oxygen species that will do superoxidation. However, this is not very sensitive because there's a state of false negative, okay? So it is replaced now by what we call the DHR test for neutrophils. So if you suspect someone, so if someone presents to you with recurrent chest infections, if you isolate unusual microorganisms like Serratia marquescens, recurrent pseudomonal infections, if someone presents with recurrent skin infection with staph, you need to keep in mind CGD, specifically if it's a female, if it's a male. And you have to do the DHR test. The DHR test is sensitive, it's good, it's cheap, and it doesn't need a very long period of time to come back the result. I mean, okay? Any question? I think we're done today. If anyone has any question, you're welcome. معي مع المحاضرة. إذا حدا قرأ المحاضرة بعدين وحس إنه في